Okay, so we'll try to move things along, and hopefully, so we'll have this over so that people, if they want to go to the Husky game, they can. It's at, I think it's about 4 o'clock or 4:45. But there's people who have been tailgating. I know some people who came here had trouble getting here because of a lot of traffic coming to the UW football game. So this is the last session that will cover the medical management of or non-surgical management of epilepsy. And I think what I wanted to do was just introduce this topic by people who may or may not know that in 2017, it's kind of hard to get the entire world to agree on the classification of seizures and epilepsy, which the first one came out in the 1980s. And in 2017, there's a new classification both of seizures and seizure types, and also very specific forms of epilepsy or epilepsy types, and then even now is still being refined as very specific epilepsy syndromes. And I think what's really important, and what I want to point out here, there's a big focus on the etiology, and genetics was integrated into this new classification of both seizures and epilepsy. And it also pointed out the importance of comorbidities. So epilepsy is not seizures alone. There's a lot of other associated cognitive, behavioral, and other comorbidities that are really critical to pay attention to, not only in terms of the other treatments, but also the medications and non-medical approaches that we have with epilepsy. So you'll hear about this, and even some of the terminology has changed. We no longer try to use the term anti-epileptic drugs. The term terminology is anti-seizure medications because the current medications have target the seizure, not necessarily the specific underlying cause of the syndrome. But this is and you'll probably see this slide again, but this is a slide that was a review from about a decade alone, where they describe the different types of seizure medications that have occurred over the last decade, but even over the last few decades, and almost a century. Because the early anti-seizure medication was bromides, but following that, the first more common medication that's even still used today is phenobarbital. But as you can see, there was a large increase in drugs in the sort of 50s and 60s. Then there came in the 70s and 80s, there was kind of a lull of drugs. And then what we often refer to as the third generation of drugs have come over in the last couple decades. But I think we're really in what I'm going to call the fourth generation of drugs, or more precision medications. There's been 6 new medications in the last decade since this review came out in 2011. But there are also some newer drugs, and that you'll hear some from Dr. Saneto on some drugs that are really now being targeted based on the underlying molecular genetics. And as Dr. Mirza mentioned, something called ASOs, that are genetically targeted therapies based on underlying genetic causes. But you'll hear about some of those medications from Dr. Owens. So the session will be medical management of epilepsy by the good Dr. Owens, dietary therapies by Dr. Lockrow, psychiatric and behavioral comorbidities by Dr. Hamiwka, and then advances in epilepsy treatment and the clinical trials that we do here at Seattle Children's by Russ Saneto. Dr. Owens.
All right, thanks very much. Happy afternoon, everyone. What a pleasure to speak to you after lunch, right? So I have no relevant disclosures. This will go on my CV or resume, so that's a relevant ego disclosure, I suppose. It's inevitable in pediatric epilepsy that you're going to talk a little bit about off-label use because much of what we do is off-label. It's the joy of working with children, so some of that will likely happen. Here's what I'm hoping that we'll all get out of this nap opportunity. Feel free to take a nap. I will not be offended. I've got 2 kids at home. I'll probably doze off for a little bit myself. We're going to talk about how we decide who we treat with medicines. We'll talk about how we choose which medicine, because if you have children with epilepsy, that may feel just a little bit like throwing a dart at a dartboard sometimes. That sometimes is an approach some people may take. How and when we change the plan from the medicine the child's currently on, when we decide to stop treatment, and then kind of how well all this works, which you've heard a little bit about already. So how do we decide who to treat? So we start with patients who meet definition for epilepsy. So that's having had a couple of unprovoked seizures separated by more than 24 hours, right? Or a patient who's had a seizure with a risk for recurrence that's really high, basically. So you think about a child who's had 2 unprovoked convulsive seizures separated by a couple of weeks. That patient would be a really good candidate to think about anti-seizure medicines. Or you think about a child with childhood absence epilepsy, right? So we may capture a single absence seizure during their EEG, but we know that those kids likely have lots and lots of seizures. So we don't have to wait to see another one. We can go ahead and move forward with treatment, or at least discussing it. But of course, not all patients. So let's say instead of 2 weeks between their seizures, there's 2 years, or in the case of some patients, 2 decades between those seizures, right? So there's obviously some gray zone there. They may meet definition for epilepsy, in other words, but we may decide not necessarily to treat. Also, there are self-limited epilepsies of childhood where we know that patients with this particular EEG features and these particular kinds of seizures oftentimes have very few seizures, or maybe just 1 or 2, and that it will go away in time. And so those patients we may decide not to treat. And as Dr. Novotny already pointed out, our medicines are really anti-seizure medicines and not anti-epileptics. And so what we mean by that is they don't seem to stop the underlying epilepsy. What they do is they stop the seizure. So it's a little bit like taking ibuprofen to take the fever away. That doesn't treat the underlying infection that made the seizure happen in the first place, or the fever happen in the first place. So we want to think about medicines that can try and keep the seizures away, understanding that that may not change the underlying epilepsy. We got a lot of choices, right? I didn't put them all on the slide because I couldn't figure out how to fit them all in. I'm really bad with PowerPoint. So there's good news and bad news in this slide, right? The good news is that we've got lots of options. I guess kind of the bad news, though, is we have a lot of options because no one of these medicines work for everybody, right? In fact, unfortunately, for a lot of our patients, none of these medicines work as well as we would like. So a lot of options, but we do need a lot of options because it's hard to tell what medicine will work best for any given patient. I mentioned the older AEDs, now that I'm getting older. Just to say, sometimes there's a knock against some of these older medicines. Turns out they work about as well as the newer medicines. They just oftentimes will have more in the way of side effects. But we'll talk about my favorite of the older medicines, ethosuximide, in just a second. Okay, so we get a lot of options. So how do we decide which drug to choose, right? And a lot of this is obviously common sense, but a lot of things we need to think about as we're approaching which drug. So first of all, we have to think about what seizure the patient has, what type of seizure, and is there any evidence that a particular medicine is more helpful than others for that kind of seizure. So, for example, patients that have tonic seizures, where they just have stiffening, no subsequent jerking, there's at least some evidence that rufinamide is more effective than some other medicines for those kinds. So oftentimes those patients will be put on rufinamide. Atonic seizures, where they just lose tone, a lot of those patients will respond better to clobazam, right? So they may get put on clobazam. So sometimes the type of seizure will give us some indication of which medicine might be best to start with. Unfortunately, we don't have a lot of evidence, kind of head-to-head trials between medicines. Which is better, kind of the celebrity death match between medicines. Which will win out, right? Clobazam versus rufinamide. We don't have that kind of data for a lot of things, unfortunately. We do have it, fortunately, for one of the most common kinds of epilepsy, which is childhood absence epilepsy. This is a great example of collaborative research. We had a big trial done, Seattle Children's participated in this, comparing valproic acid, lamotrigine, and ethosuximide for treatment of absence. And after analyzing all the data, it turns out that ethosuximide, which came from the 1960s, just like me, was actually the most effective in terms of treating the seizures, but also being well tolerated, because of course those are both really important. We just don't have that kind of evidence for really much else in terms of pediatric epilepsy spectrum. Speaking of spectrum, narrow spectrum versus broad spectrum, what I mean by that. So again, picking on ethosuximide, my fave, right? So ethosuximide really only works for absence epilepsy in most circumstances. So it doesn't treat other things well at all. Whereas one of my other favorites, old drug, valproic acid, treats any kind of seizure that you can imagine, at least in some patients. So it's a broad spectrum drug. And so we want to think about, do we need a narrow spectrum or broad spectrum when we're choosing a medication? Do we know for sure what kind of epilepsy this patient has? Do we know for sure that it's focal or that it's generalized, for example? If we don't know absolutely for sure, we might think about a broader spectrum drug. Or if a patient has more than one type of seizure, we might think about a broader spectrum medication. Side effect profile. All of our medicines have side effects. We all know this. I think tap water probably has side effects. Everything has side effects. And side effects are unpredictable, too. You know, the long list that you get from the PDR with pretty much everything from, you know, serious liver failure to like explosive diarrhea to all sorts of things, right? That's one of those is true for every single patient. And the only way to know for sure is to see how any given patient responds to that medicine. We want to think about the common side effects that we've seen and how those would likely work with this particular child. So a child who tends to be sleepy, you may not want to use a sleepy medicine, right? A child who won't go to sleep at night may actually do well with the medicine that will make them sleepy at night, right? So sometimes side effects can be to your benefit. So being mindful of that and what the child's already wrestling with, trying as much as possible to stay out of their way is kind of our goal, right? Other conditions, let's say the child has a liver condition, you may want to avoid things that might exacerbate that. So obviously lots to think about there. Potential for drug-drug interactions. There's two ways in which that can come into play. One of which is medicines can sometimes change the way that they are broken down or metabolized, right? So they can increase the level of each other, decrease the level of each other, interact in ways like that. And that's something we have to be mindful of. Sometimes by adjusting the dosage or simply just avoiding medicines that interact in that way. Sometimes actually that can be to your benefit. So a medicine that will increase the level of the other medicine sometimes can actually help that medicine to be more effective, right? So valproic acid and lamotrigine are oftentimes used together with exactly that intention, right? Because valproic acid will increase the level of lamotrigine. So sometimes these things can be helpful. Also, when you just start piling medicines together, and some of you unfortunately may know this from experience, they tend to bring out the worst in each other, right? So if you are on two medicines, both of which tend to have sleepy side effects, you will tend to be even sleepier on those two medicines than you would be on either one of them by themselves. So we have to think about how they interact. Formulations. It turns out, much to my chagrin, that actually taking pills is not a natural, innate human thing, right? I know this from trying to get my 7-year-old to take like an ibuprofen. He said, no, I'm not going to swallow that. But you swallow it, and we've had long discussions about this. So we need medicines with different formulations, depending on the ability of the child to take pills, for example. Is there a dispersible form? Is there a liquid form? If we need to give it quickly, is there an intravenous form? So formulation is really important. The more, the better, basically. And then, of course, we have to be really practical. You know, will the patient's insurance pay for this medicine? It could be a great medicine, right? Most of our medicines are not the kind of thing where you should mortgage the house for it, though, right? If it was a cure, absolutely. But most of them aren't cures, right? So let's think together about medicines that are going to be covered and that you can actually afford. Do you need to do testing beforehand or, more importantly, afterwards? So, for example, I have patients with really severe autism who do not like their blood to be drawn. It takes either 20 people or general anesthesia to get their blood drawn. I would not do them much service to put them on a medicine where they're going to need every 2 to 4 to 6 month blood draws, right? So that's something to think about. It may come to that in time, but it's not what I want to start with. And then the last line, to be honest, is something that we oftentimes fall back on, which is provider experience and comfort. There's a lot of medicines there, and we all have different levels of comfort and experience with them. Some of us who are a little older, like Dr. Novotny and I, are more comfortable maybe with some of the older medicines, right? But we still use the new ones as well. We're hip and cool. So that really does come into play. So, I mean, you could ask, with all that having been said, why is it always levetiracetam or Keppra that we start with, right? And it's actually, I think this actually well illustrates the points I just made, right? So levetiracetam is broad spectrum. It's available in lots of formulations. It doesn't have any true drug-drug interactions because it's not metabolized by the liver. There's a very low rate of serious adverse reactions, right? Although if you've seen kind of levetiracetam rage, that would seem like a very serious adverse reaction, but it does go away if you stop the medicine, right? You don't need to test beforehand. You don't really need to test anything afterwards. So it fits a lot of those boxes that we talked about before. And then again, illustrating that last point I made on the last slide, providers tend to be very comfortable with it. So there's a reason why it's probably the most commonly prescribed anti-seizure medication in the United States and elsewhere, because people are comfortable with it for lots of reasons. And it's inexpensive. A tablet of levetiracetam costs about 5 to 20 cents, depending upon what your plan is. Okay, but let's say, as sometimes happens, tragically, levetiracetam does not work. What are you going to do next, right? So when do you decide to move on to something else, and how do you do that? So remember that lots of anti-seizure medicines, ASMs for those of us who are trying to be cool, they have a broad range of doses. And so we want to think about working up through that dosage range to the point either where it's working or the side effects get to the point where it just really is not a horse we can continue to ride, right? Clearance varies. So let's say you're getting to a higher dose, the patient's tolerating it, but it seems like it's not working as well as you might expect. Worth checking levels oftentimes because clearance can vary greatly by age and also just individually by patient. So for example, younger kids tend to clear to pyramate quickly, so they may require much higher doses than older kids or adults would. And then mentioning the heartbreak of the honeymoon period, which a lot of my patients unfortunately experience, where you put them on a medicine and it works great for a week or 2 weeks or a month or 2 months, and then it stops working and the seizures start coming back. And so you go up on the dose as we do, and then the seizures come back after another month or two. That kind of honeymoon phenomenon is a real phenomenon. It's basically tolerance. The neurons are getting better at getting rid of the medicine, right? So if that's a pattern that we're seeing, then we tend to say that's just not a medicine we can continue to work with and move on. How do you choose what medicine to try next? Well, of course, you're going to think about all those same things that we just talked about. Important, though, to think about why did the first drug not work, right? So if it didn't work because the patient couldn't tolerate it, in other words, the seizures were pretty well controlled or well controlled, but the side effects got you, right? Then maybe you could think about a medicine in that same class that might have a better side effect profile. You know, oxcarbazepine made him sleepy, but it controlled the seizures. Maybe we try eslicarbazepine or lacosamide or something else like that. What if it didn't work at all? Probably better than to move on to a different mechanism of action, of which we have several to choose from, right? Always remember the type of seizure that you're treating. So if you put someone with generalized epilepsy on one of these narrow spectrum drugs, sometimes that can be likely to make things worse, right? The new drug should play well, at least temporarily, with the old drug because they're going to be on them both for at least a period of time. And we'll talk about how we do that in just a second. But we want them to not make things worse when they're given together. And then the same issues of formulation and affordability and so on that we just talked about. Nope, not going backwards, I promise. Right. So how are you going to start the second medicine, the next medicine? There's the Novotny way and the Owens way, right? His way's better, he's the boss. But the way, so you could either do it sequentially, where you take the new medicine, you build it up to a therapeutic dose, right? A low therapeutic dose, and then, assuming it's working well, start to take away the old one, right? That's my way. The disadvantage of that is once you start trying to take away the first medicine, the older medicine, oftentimes seizures will start to come back or increase, and you can end up kind of stuck on 2 medicines when you wanted to just be on 1. So that can be a problem. The cross-titration approach, Dr. Novotny's approach, would be you come down on the old and up on the new, and you end up on just 1 medicine. So you have to do 2 things at once, which the reason I don't do it that way is just because I'm simple-minded and can only do 1 thing at a time. Dr. Novotny is much more complex. It can be a challenge sometimes to know exactly what is causing what problem when you're adjusting 2 medicines at the same time, but usually you can figure that out. been through this before, so I won't belabor it. Just to remember, any patient who has not become seizure-free, that would be how I would describe it. A patient who's not become seizure-free after a couple of medicines deserves an evaluation to see if there's other things that we can do. Our goal is always to make patients seizure-free. And you heard Dr. Hauptman running down medicines as surgeons do, that even after the first one, if there is a surgical option, want to think about that even earlier. When and how to stop treatment. So again, we generally aim for 2 years of seizure freedom on medicines. If a patient's been seizure-free for 2 years, then we think about trying to take them off and see if they even still need medicine. Unfortunately, it's kind of the only way we know for sure whether they need it or not is by trying to take the medicine away. We think about things like the type of seizure. Patients who have convulsive seizures are less likely to be able to come off medicine, though still worth a try. The type of epilepsy, so childhood absence epilepsy, other epilepsies that go away in time anyway, obviously much more likely to be seizure-free off medicine than epilepsies where we know that patients continue to have seizures by and large. So juvenile myoclonic epilepsy would be an example of that. One thing we appreciate about epilepsy more and more is that patients will tend to have long periods of seizure freedom, right? And then seizures come back, for at least some patients, while this variable pattern of their seizures. And so sometimes you just are treating during a period when seizures otherwise wouldn't be happening frequently. You take credit for it because you prescribed a medicine, but it was really just the child's brain had decided not to have seizures for that period of time, right? Degree to which side effects are bothersome. So if a child is having a lot of side effects on a medicine, maybe trying to take it away earlier, right? Our medicines can be given long-term, so medicines now are much better tolerated over the long haul. Right? If you've tried to take medicines away and the seizures came back, there's really only a slightly increased risk that seizures will come back with a second attempt to take medicines away. So still worth trying. It's always worth trying. I'm a hopeful guy, right? Though patients who have abnormal imaging or abnormal development are less likely to come off medicine over time. That's a risk factor, does not mean that it's not worth trying again. Is the EEG useful before weaning? EEGs are great because they give us something to do, but they can sometimes be less helpful than we would hope. So if your EEG is normal, increases the chance that seizures will not come back, but sometimes, it still happens. It's not a guarantee. Also, sometimes patients can continue to have interictal findings even when their seizures, their clinical seizures have stopped, right? How do you wean? You can either wean by intentionally taking down their medicine, no faster than the increments by which you went up on the medicine in the first place, or you can just stop adjusting their dose for their weight. And for younger children, they will soon outgrow their dose to a point where it becomes so low that you say, well, we can stop now. That's the really grow slow approach. Right? How will this all work? You already heard this before. About 60% of patients become seizure-free overall. About 59% of patients in a 2013 study were well controlled, 25% did not respond fully to medicines, and about 16% again fluctuate. They'll have periods of seizure freedom punctuated by periods where seizures are returning. So that's what I was going to try and tell you. That's me. Thank you very much.
Hi, so I am Jason Lockrow. I'm the head of the Epilepsy Diet Program. We also call it the Ketogenic Diet Program. We'll sort of talk about why that is. I have no disclosures. And really what I want to talk about today is review some of the basic metabolic changes that occur with fasting and with the type of things that would occur with the ketogenic diet. Contrast how some of the other diets that are done that are low carbohydrates are different from the epilepsy diet that we utilize, highlight epilepsies which may benefit from dietary therapy, and then really kind of identify who may be a good candidate. There are very few perfect candidates for the ketogenic diet, but a number of children can really benefit. So in terms of the history of the dietary therapy for epilepsy, it's been described for a really long period of time. As far back as Hippocrates in the King James Bible, there are references to using fasting as an epilepsy treatment. But it really wasn't until about 100 years ago in the 1910s that both physicians in France and in the United States started investigating why this fasting seems to help. And there is really a number of physicians showed that with fasting you see a significant reduction in the number of seizures. And Cobb and Lennox showed that these seizure benefits really begin at around 2 to 3 days. So shortly after it was identified that there were these things called ketones or beta-hydroxybutyrate, which occurs both in the setting of starvation, but also in the setting of a diet that has very limited amount of carbohydrates. And that same year, Russell Wilder created a diet to create sustained ketonemia, or ketones in the blood, without actually having to require fasting. And his diet is very similar to what many of the diets are utilized today, and that's 1 gram of protein for every kilogram of body weight, only about 10 to 15 grams of carbohydrates per day. This is extremely little. This is about the size of a small apple a day. And then the remainder of calories, which comes from fat. And for a period of time, this was actually used quite frequently and quite successfully. Some of the early studies 100 years ago showed that almost 50% of individuals showed seizure control, and 8 out of 10 people showed a significant reduction in seizures. But then phenytoin was discovered, and as Dr. Owens so eloquently pointed out, all of these medicines were so much easier to utilize. They're much easier to administer, and they really de-emphasized the use of the ketogenic diet for a long period of time. But despite all of these medications, as numerous speakers have pointed out today, only about 30% of these childhood epilepsies are actually drug resistant. And so that's where we think about surgeries with resective surgeries that Dr. Hauptman talked about, or neuromodulation or corpus callosotomy that Dr. Bozarth and Dr. Goldstein talked about. But another possible treatment is some sort of dietary therapy, which is different than a cure that can occur with resective surgery, but may have a similar place with some of these other neuromodulating treatments. So when we think about dietary therapy for epilepsy, there's lots of different terms and lots of different diets that can be utilized. We tend to call it the ketogenic diet because this is the production of ketones, and that's the most commonly thought of, but there is a modified Atkins diet that we utilize as well. There is a low glycemic index therapy. There's a medium chain triglyceride diet. There's also intermittent fasting and caloric restriction. All of these have been shown to be helpful in the setting of seizures, and they all work in somewhat of a similar way in that they are taking advantage of some of the adaptations to fasting. And so this looks at some of the changes that occur over the course of hours to days when you are getting an insufficient amount of carbohydrates. You use all the glucose in your bloodstream, you start producing glucose by breaking down glycogen, and then you start creating glucose through gluconeogenesis, and that comes from both carbohydrates and protein. But eventually you start depleting the amount of glucose available in the body, and something that can't be converted into glucose are fatty acids. And fatty acids start being converted into something called ketone bodies, which is why we think of the ketogenic diet. So there are lots of different types of ketogenic diets. These are high-fat, low carbohydrate diets. They are intended to limit the amount of carbohydrates available. They trigger fat metabolism and they produce ketones, which can serve as a form of energy. This has been utilized for many different factors, both for weight loss. There's the Atkins diet. People use this as other lifestyle diets to improve their health and other perspectives. And there's all validity behind a number of these different types of diets. And many of the things you find online show these to be really helpful and healthy diets where you can eat a very broad variety of foods, as pictured here. When we think about the dietary therapy for epilepsy, it is similar to that, but it's a little bit more extensive because it's not just the requirement of mobilizing those ketone bodies, as you can see by that KB. You actually need to have a sustained period of time where you are at a lower level of glucose, and what that does is that triggers the brain to start bringing in those ketone bodies and using that as a form of energy. So the liver converts acetyl-CoA to ketones. Ketones enter the blood and they cross into the blood-brain barrier, but it actually requires a upregulation of an enzyme, beta-ketoacyl-CoA transferase, that actually allow those ketones to be integrated and utilized as a form of energy. And we actually think that it's, at least in part, the neuronal utilization of ketones underlying the benefits of dietary therapy. And so when we think about a lot of these lifestyle diets to be really kind of healthy and removing a lot of the carbohydrates, the grains, the pastas, when we think about the ketogenic diet, it is actually far more strict. And it is a strict ratio of fat to carbohydrates and protein. It really requires weighing of food. The classic ketogenic diet is 4 grams of fat for every 1 gram of carbohydrates and protein. This is a significant reduction in the number of carbohydrates. You get more than 90% of your calories from fat. And really what it looks like is, rather than that type of thing, it really looks more like this, where it's heavy whipping cream, it is maybe mayonnaise, there is a little bit of chicken, there is a small amount of vegetables, but it really is quite restrictive. And that's because you not only are trying to create those ketones, but you're really trying to force the brain to utilize that as a form of energy. So why do we do all of these changes? And that's because the ketogenic diet actually can be quite helpful for seizures. This is an old study now. It's done more than 20 years ago, but everything it shows really still stands out, and many of the studies have validated these findings. This was more than 150 children at Johns Hopkins who have drug-resistant seizures, so have gone through multiple medications that have not been effective. And what they found is that a substantial number of these children see a reduction in the number of seizures. Not many are seizure-free, only 4, 5, or 11 patients in this cohort, but more than 50% of them have a greater than 50% reduction in seizures. And then when you look at the specific types of seizures that benefit, it's some of the seizures that are most harmful to children. And those are the tonic-clonic seizures and the drop seizures, where you see more than 80% reduction, or at least more than 80% reduction in these seizure subtypes. When we think about specific types of seizure disorders that really benefit from the ketogenic diet, the easiest one to think about is something called GLUT1, which is a mutation in SLC2A1. This encodes for a protein that transports glucose across the blood-brain barrier. So if you're not able to bring glucose into the brain, you're going to have a deficiency in glucose in the CSF. This results in a fairly broad array of symptoms, including at the most severe acquired microcephaly, movement disorders, and epilepsy. Now, what the ketogenic diet does is it bypasses this need for glucose to the brain, because you're actually incorporating those ketogenic or those ketone bodies as the major source of energy. And what that does is that ketones from the ketogenic diet really change the risk for seizures. Many of these individuals either have a drastic decrease in the number of seizures or become seizure-free, and many of the other comorbidities that come with GLUT1 stabilize. And so we think about a number of syndromes, particularly genetic, that really can benefit from the ketogenic diet. So myoclonic astatic epilepsy, this is something that's also known as DUCE syndrome. This is a seizure subtype that tends to start at 2 to 4 years of age and results in explosive onset drop seizures at the very beginning, and then eventually evolves into very frequent generalized tonic-clonic seizures. Very few medications seem to be helpful. These children are often refractory. But the ketogenic diet is extremely beneficial. About 50% of these children become seizure-free on the diet. And this is particularly useful in this population because many of these children will eventually outgrow their epilepsy 4, 5, 6 years down the road. And so there's a very specific amount of time that if you can bridge them through this, the highest risk period of seizures, they may not need to be on this dietary therapy for life. We'll hear, we talk about Dravet syndrome during this symposium, but this is something that there are many medications that can be very helpful for Dravet, but the ketogenic diet is almost as beneficial or as beneficial as even some of these newer medicines. Dr. Randall discussed with Angelman syndrome, or with tuberous sclerosis, and then also with Angelman syndrome. Both of these types of disorders have been shown to really benefit from multiple different types of epilepsy therapies, both with the ketogenic diet, also with somewhat more lenient diets, such as the low glycemic index therapy. Dr. Mirza talked about heavy megalencephaly and other malformations of cortical development. These are types of syndromes which really benefit from surgery, but the ketogenic diet can be useful either in children where surgery is not an option, or if you're trying to bridge them to surgery. It can significantly reduce the seizures and the comorbidities associated with seizures until they are actually able to get a surgical treatment. And then the last thing I'll bring up is FIRES, or febrile infection-related epilepsy syndrome, or superrefractory status epilepticus. These are types of emergent onset seizure disorders that really respond to very little treatment. Medications are not effective, and there are very few treatments that seem to benefit them at all. And the ketogenic diet may actually significantly reduce the seizures even when no other treatments are effective. And getting them onto the ketogenic diet extremely quickly and avoiding some of the drips and other medications that may not be effective can actually be something that really changes the trajectory of their epilepsy. Even outside of some of their earliest considerations, there are a number of drug-resistant epilepsies that can really benefit from the ketogenic diet. These are epileptic encephalopathies such as infantile spasms or Lennox-Gastaut syndrome. These children have a lot of medications that are available to them. They have a lot of other therapies that are available to them. The diet is rarely the only option, but it certainly can be an avenue to reduce the number of seizures when either neuromodulation or medications are no longer effective. We even do this in genetic generalized epilepsies. These are your absence seizures, your juvenile myoclonic epilepsies. We really recommend starting with treatments or medications first. But if multiple medicines are not effective, this can be something that improves the quality of life. There are contraindications to the ketogenic diet, and the major ones revolve around the inability to break down fat appropriately. So if you are not able to mobilize that fat, either by breaking it down with fatty acid oxidation disorders, by bringing it into the energy-producing parts of the cell, the mitochondria, which requires carnitine and carnitine palmitoyltransferase, then something like the ketogenic diet is actually quite dangerous because you're not going to be able to use ketones as a form of energy. If you're unable to tolerate fasting, such as with acute intermittent porphyria or pyruvate carboxylase deficiency, you're actually not going to get to the point where you can start creating ketones safely. And then if you have an inability to maintain hydration, or in order to eat enough calories, so if you have swallowing or dysphagia, poor inadequate hydration, or inability to maintain weight, all of those make the ketogenic diet much more risky. We do think of this as something that may lead to weight loss. And if you're unable to maintain weight even before the ketogenic diet, that is something that we really try to identify before starting someone on the ketogenic diet. So when we think about the challenges that come with the ketogenic diet, a lot of it revolves around not necessarily the impacts on the brain, it's all the impacts on the other parts of the body. So fat metabolism it's much harder than metabolizing proteins and carbohydrates. It slows down the gut. It can lead to reflux, constipation, and dysmotility, which are comorbidities that are seen in children with epilepsy. It significantly impacts bone health. Many of our children have osteoporosis that we try to avoid as much as possible, but it's hard to avoid it entirely. There's an increased risk of kidney stones. Obviously, you're providing a large amount of fat, so you can see hyperlipidemia. And then it's trying to make sure they maintain a healthy weight, that they're continuing to grow, that they have they don't have any nutritional deficiencies. And the last thing we think about is the ketones, since we're really using this as a treatment, they can vary depending on changes that occur with the diet or maybe changes that are unexpected. If your ketones go too high, it can lead to nausea, encephalopathy, vomiting, and that may further impact your ability to eat. And similarly, if you're using ketones as a treatment, if those ketones drop, you may see a rebound in seizures. Some of the biggest challenges with the ketogenic diet is actually compliance. And as Dr. Bozarth and Dr. Goldstein talked about, the VNS is placed, but once it's placed, it's kind of on autopilot. This really requires a huge amount of time and effort from the entire family. Really, the caregiver and support and adherence is extremely important to all caregivers, including the ones that are involved with them at school. It really, for older individuals, requires participation of the child. If this is something that they do not want to do, this is not necessarily going to be a great diet. And it does require extensive monitoring. It requires a lot of blood tests and other biometric measurements. Ketogenic diet is a lifestyle. The diet is hard to maintain. Carbohydrates are everywhere. They are in toothpastes, in medicines, even in sunscreen. The diet is extremely limited. It's not quite as limited as it once was, as there are a number of different ways to do the ketogenic diet, including recipes and other ideas. But it is still quite challenging. It's more prone to variability than a medication that you can prescribe and give twice a day. The side effects are typically manageable, they're not insignificant. And as I mentioned, it just requires a lot of support. We have extensive caregiver education prior to starting the diet. We have social work who we really rely on to help navigate some of the barriers that families have socially. And then we require frequent visits with the dietitian, labs, measurements. In terms of our dietary program, we do a pretty extensive intake where we have an epilepsy evaluation, where we try to get a diet log of exactly what the child is eating. We do a diet assessment with registered dietitian, our nurse practitioners, and social work. We try to identify any problems that may occur beforehand. A lot of what we try to do in an epilepsy evaluation is not only to get a sense of whether this is something that they may benefit from, but also really just kind of clarify the risks of the diet and how they may benefit from the diet itself. We do two types of diets in our program, the ketogenic diet and the modified Atkins diet. The ketogenic diet we really emphasize in our formula-fed children, either infants or individuals with a gastric tube, because it really requires that fixed ratio of foods. It requires a lot of weighing, and it's actually quite amenable to a formula, but it's much harder for someone who's eating by mouth. They do a 3 to 4 day admission for an inpatient start, where we really watch the patients closely and do a number of teaching while they're in the hospital. We also do a modified Atkins diet. These are for oral eaters. We rely on their ability to maintain hydration and feeding goals. A lot of this is all done as an outpatient. So we do significant teaching and do an outpatient start prior. The modified Atkins regimen is very similar to what was described 100 years ago. It's 10 to 15 grams of carbohydrates, protein with each meal, and really fats as much as possible. So we think about optimal candidates. We really think about whether they will benefit. So do they have a specific drug-resistant epilepsy? Do they have an epilepsy syndrome or seizures more likely to respond? And then we also think about secondary benefits. This may allow us to reduce the medicines that a child is on. We do see some improved alertness, and there may be potential for cognitive changes that occur with the ketogenic diet. This is also the possibility for a family to really take control of the management of their patients. It is very time consuming, but some families really like to take that ownership and feel it is extremely empowering. And we want them to have realistic expectations about the possible outcomes. This is unlikely to make you seizure free if you're drug resistant, but it really can be helpful. And then in terms of challenges, we talked about the medical and the social barriers, but it comes down to, are they able to get the calories? Are they able to get the hydration safely? And that may mean that they can do this by mouth. It may mean that we really have to rely on a gastric tube. And we really require them to adhere to the strict regimen. So the things that I would kind of take away is that epilepsy diets can be effective at seizure reduction when medications fail. It is always something to consider as an option, particularly in drug-resistant cases, but it is rarely the only option. They are extremely strict and they are challenging to administer, and really they require close medical and registered dietitian supervision. And I don't recommend doing this by themselves. And just like with medications, consistency and reliability in administration are necessary to limit side effects and troubleshoot issues. And I think the more that families really adhere to the strictness of the diet, they can really benefit. So thank you.
All right, good afternoon, everybody. So I am tasked with talking to you about psychiatric comorbidities associated with epilepsy. This is something that has been a passion of mine for over 2 decades now. So away we go. I don't have any disclosures. And my goals for today are to review the importance of identifying these, to discuss, I want to discuss cognition because I think it really plays a role in how we deal with neuropsychiatric comorbidities. And I wanted to provide maybe a little bit of guidance around the diagnosis and treatment. So identification and treatment of comorbidities, I think, and most of what is in the epilepsy literature now thinks are important for comprehensive epilepsy care. It can affect the quality of life for the child and the family, and sometimes be more significant than seizures themselves, and I hear that very often. And just to remember that cognitive and psychiatric comorbidities are really common in the children that we see. So studies conducted over the past several decades, probably more than 30 years now, have confirmed these high rates of both cognitive and psychiatric comorbidities. And if you look at even older data from Gastaut and before the time, these reports of behavioral and cognitive changes are certainly there as well. Psychiatric comorbidities are about 5 times higher than the general population. The most common that we see, and this has been discussed in other talks as well, are ADHD, anxiety, and depression. And I think the coexistence of developmental disorders can really complicate this diagnosis for us. They're present in new onset epilepsy and chronic epilepsy, and there are many studies showing us that these symptoms are prior to the onset of epilepsy diagnosis in many cases. They're also present in kids who are controlled medically or have been treated by surgery. So although surgery often makes children seizure-free, the other comorbidities persist. So should we talk about these as comorbidities in epilepsy, or is this really broad spectrum illness? And this has been something that has been discussed at least for the last decade. The disorder is multifactorial, multifaceted, and varies in severity from individual to individual, which would suggest spectrum illness. So the seizures, which are often the focus of clinical care, those often have a spectrum from remission to refractory. And the comorbidities or coexisting disorders are high. They're high for cognition, developmental, and psychiatric difficulties. There are many potential risk factors. We kind of divide these up in illness-related or biologic variables, so related to the type of epilepsy, age of onset, duration of illness, and medications. There are also psychosocial variables, so stressors and adaptive resources for the children, families, and even adults. Coping and family adjustment, lots of work done in this field too, and affecting these comorbidities. A family history of ADHD, intellectual disabilities, and mood disorders is also a huge risk factor. And then intellectual disability itself, and particularly verbal IQ and language deficits. So going forward into cognitive difficulties and intellectual disability, about half the children with epilepsy have cognitive difficulties, and maybe about a quarter struggle with even more significant intellectual disability. They not uncommonly exist in both the self-limited or epilepsies that go into remission and the generalized genetic epilepsies, which sometimes are not lifelong. Cognitive difficulties, they may be related to the underlying cause of the epilepsy and thus may continue to be a concern or can progress even if the epilepsy does not progress. They may in some cases be related to epilepsy severity, and so they can improve with seizure control or changes in the EEG over time that are affected with medications and other treatments. But that's not always the case. I think early screening and ongoing evaluations that start at diagnosis are really important. I'm going to talk later about barriers and difficulties with some of the screening. I think evaluation prior to school entry is really important, or if it's an older child at diagnosis, and then moving forward with IEP and 504 considerations as early as possible and in those younger years. I'm going to move on to ADHD now. I know you've heard of the prevalence. If you look at prevalence, it's anywhere from 28 to 70% in studies, so very wide range, and very much dependent on the population studied. And that's much higher than the general population at 5 to 10%. The concern is that the children with epilepsy often present with inattentive features and are not the hyperactive children, so there can be a delay in the diagnosis. And the adolescents that have ADHD are more likely to have comorbid ODD than adolescents without epilepsy. The ADHD, again, can be present prior to or at the time of the diagnosis of epilepsy, typically higher risk when they're younger, seizure onset, more frequent seizures, or have refractory epilepsy. Unlikely a direct result of seizures or anti-seizure medications, but as I will talk about in a little bit, anti-seizure medications may induce or worsen symptoms. So the treatment is really multimodal: behavioral modification, parent training, and then really important to have cognitive and school supports. And then also co-use of medication as necessary. I like to use consultation with ADHD clinic or psychiatry for co-management, both in behavioral modifications, but as well for medications. The medications often require close follow-up. We now know from studies that medications have been looked at in ADHD with epilepsy. We know that methylphenidate is safe and it's effective for most patients with epilepsy and ADHD. Amantadine's also been used, although not as well studied. For mood disorders, there's a bidirectional relationship between mood disorders and epilepsy, suggesting common pathologic mechanisms. And this is especially true for depression. And so maybe that raises hope for future therapeutic interventions that target them together. Depression tends to be more common in association and anxiety as well with frontal and temporal lobe epilepsies. Prevalence for anxiety is anywhere from 17 to 36%. I think that's probably an underestimate, particularly post-COVID and the ways of the world. Pooled prevalence, though, is about 19% reported in the literature. Worries can be generalized or very specific to the epilepsy, and those are the fears of having a seizure in public, dying during a seizure, and in particularly the anxiety that seems to be related in children with epilepsy is more of a social anxiety as opposed to a generalized anxiety. And so that, I think, is becoming more important as we talk about anxiety in epilepsy. There's no difference when you compare children with epilepsy to chronic disease controls. I've done some of the work in the past. I've also compared children with epilepsy to typically developing or healthy controls. And when I first did the studies, as early as 2000, there was this big difference between children with epilepsy and children who were just their classmate controls or their best friend. However, when I repeated that study about 10 years ago, I couldn't find a difference. And so I went to the literature and realized that anxiety in everybody was going straight up. So now the measurable difference is really doesn't seem to be there anymore. Prevalence of depression, 8% to 23% reported in the literature. Again, I wonder if that seems low sometimes. In adults, though, the reports are twice as high. Treatment. So first line for mild to moderate depression is really psychological intervention, so counseling or CBT. Pharmacological treatment in combination with psychological intervention is used in moderate to severe depression and anxiety. There's limited data to suggest, at least in adults, that the SSRIs and newer antidepressants are safe in epilepsy. And most of the literature is really around citalopram and sertraline to be used as first-line treatments. Pediatric data for response rates is really limited. Most of the response rates reported that are, successful response rates are really in our adult populations. I felt like I needed to talk a little bit about suicide. suicidal ideation and suicide attempt, because I think it's a really important topic right now. Rates within epilepsy are reported as 14 to 20%, 27%. The risk of suicide attempt reported in the epilepsy population is about 1.8 times the control population. And when they're compared to controls, depression and substance abuse were not clear risk factors, which they are in other populations. When compared to control, high rates of these children had comorbid ADHD. And I'm happy that we now have suicide screening programs in the clinic patients. And I think that's a big win, just in terms of early identification of ideation and thoughts, and we can sort of talk about those actively. Anti-seizure medication effects. So separating anti-seizure medication effects and psychiatric comorbidities can be a difficult task. Underlying and particularly undiagnosed psychiatric comorbidities can be confused with anti-seizure medication side effects and can often lead us to unnecessarily change medications. And we know that just given the literature suggesting that many of these symptoms are there prior to diagnosis of epilepsy, really important to address these at the first visit or very early on in epilepsy diagnosis and treatment considerations. Other treatment forms, such as the ketogenic diet, which you've just heard about from Dr. Lockrow, and small trials have documented really no or negative effects and possibly improved cognition and anxiety symptoms, similarly so with the VNS, but these are all huge talks that could be done independently of this one. I've kind of laid out a slide, kind of looking at what seems to be in the literature. There are some conflicting data, but we know that a lot of what we've called or the traditional older medications can have higher association with some negative effects, but not always. There are lots of new medications that are also on this list. There are ones that are felt to have positive behavioral effects, and then medications with uncertain effects on behavior, and then ones that we really just don't have any data on. I will say, though, that recently I've seen some stuff on the cosamide that may be pushing it toward the positive effects. But I put it in uncertain because the population studies are really small and it's difficult to tease out. So just to be wary, and I think about this a lot myself, if I've got clear diagnoses, what is the right medication to use or maybe to start not to exacerbate symptoms. But however, I think sometimes the best medication for the epilepsy may come with some potential increase in side effects. So how can we help? Early identification and screening, I think is really important, and I have pushed for this for a very long time. I have, and I'll talk a little bit about this, I have piloted early screening. I think assessments at diagnosis are really important in terms of treatment for the epilepsy and for treatment of the underlying comorbidities. And I think probably need to be done at least yearly. And then, consideration of IEP and accommodations really early within that school time. Collaborations with psychiatry and psychology and social work, mood disorders clinics, getting testing done, and community mental health resources. And then again, just support groups within the community or school support groups are really important as well. I did do a busy screen, and I apologize, I tried to make it as unbusy as possible, but there are several measures, that have been considered, that have been piloted within the clinical setting that, target different things. I think my favorite one, or the one that I've used, is this pointer doesn't show very well, but is number 4 on the list, the strength and difficulties. I think it really is a really quick screener. It gets at a lot of the comorbidities in a very quick way, and then if necessary, one can further look at other measures. So from my pilot screening, I think it can be feasible. It's felt to be feasible often by staff and families. You can actually document high rates of success. And the finding from screening is the low rate of mental health services utilization in kids who screen positive. Difficulties with screening, time in a clinical setting is always difficult. So the question is, who administers the questionnaires? How do we get them scored in time in a clinical setting and interpreted? It does require clinical space. And the question is also, do we just do a simple checklist measure, or does it take also a clinical interview? And then you always have to think about, what do I do if I find a problem? And the biggest one around that is really if you find suicidal ideation or suicidality. You need to have a mechanism within the clinic to deal with that and the resources to deal with that. Barriers, we know that there are barriers that are healthcare provider related. These have been discussed in the literature. So lack of training, lack of knowledge, lack of time, sometimes misconceptions regarding medications, neuropsychiatric medications in children and adults with epilepsy, sometimes failing to educate children and families that these are as important as the epilepsy, and lack of communication with our mental health providers. There are patient-related barriers, difficulties with acceptance, and sometimes stigma, and concerns about taking yet another medication. And then the economic barriers, so lack of resources for how do we get resources in the community, especially now. Now resources are sometimes very difficult to find. So in summary, there is a wealth of data consistently documenting high rates of neuropsychiatric problems in children with epilepsy, and there are multi-factors. I review papers on this subject all the time, and we still get papers that say this is a problem. I think we need to move beyond that. We need to say, yes, we know this is a problem. How are we going to address it? We know that there are high rates of untreated symptoms, and so I advocate for screening, and screening very much probably a diagnosis, and with regular reassessments because things evolve and change. And then diagnosis and treatment are really important, I think, for long-term social, psychosocial outcomes and quality of life. I mean, we know that our adult patients who go into the adult world, even if they've had a self-limited epilepsy, are still less likely to get married, they're less likely to have families, they're less likely to be living on their own, and less likely to have groups of friends and peers that they regularly hang out with. So thank you for your time and attention, and I'm going to pass the torch.
I am the last speaker of the day. Hallelujah. Okay, so my topic is clinical trials, but really my talk is precision medicine. And the whole reason that we think precision medicine is useful is because on the best case scenario, see if I can play with this thing. My slide. Took me hours to make this slide. What we try to do in precision medicine is to devise trials that look at specific modalities of treatment that will either cure the disease, limit the disease, or have nothing to do with the disease. So the best of translational medicine is the best clinical trial. On the right, you see the input. We need clinicians. We need to know the natural history of the disorder. So if we know the drug's going to make a difference or not. And we also need clinicians to run the clinical trials. On the other side of the cliff are the researchers. The researchers need to understand the natural history of a particular entity so they can develop animal models to test. They can also develop novel therapies that are not in vogue, not being used to precisely and targetedly treat a disorder. You've heard it almost every talk. 25 to 30%, probably a little bit more, probably 33% if you're anal retentive like I am. Patients who have epilepsy are medically intractable. Our medicines don't do very much for them. Why do you think that is? Let me give you a little bit of an example. I've always been told that personal stories are the best, so you'll remember. So back when the Earth's crust was cooling, I was doing my pediatric internship at the Cleveland Clinic. And they made us go to the county hospital in Cleveland, Metro Health. That's because we got to see all the really interesting, normal intensive care patients. And those of you who know me know that I'm very addicted to Diet Coke. And so on call one night, I was stumbling around because they told me that the Coke machine was three levels down and across the hall from where the doors open. So I'm stumbling around and I get in this little room and there's these big cylinders on benches. You know, what the heck are these? There was a lot of dust on them and everything. And I finally found the Coke machine, which was in the next room, which they didn't tell me. And so I went back, and in the morning when the attending finally showed up on rounds, I asked him, "What are those?" He said, "Russ, those are iron lungs. During the polio epidemic, there were wards filled on left and right sides of these iron lungs. They saved hundreds and hundreds of patients who had polio." And I thought to myself, well, that's really interesting. I wonder why I got those dumb vaccines for. But as it turns out, it took a couple really smart infectious disease people, Salk and Sabin, to figure out how to cure the disease. How could they do that? Because they knew that an enterovirus sloughed off from the intestines caused the disease. They had, in our field now, a genetic etiology. So now they knew what to shoot for, literally in your arm. But Sabin had a better way with little salt things. So actually, they were sugar cubes. And unfortunately, he spreads live virus, his method. But it's almost unheard of unless you live in Rockville, New York, to have live polio vaccines, right? Viruses. So we need to know the etiology of what we're trying to treat. And in epilepsy, the reason why there's over 55 seizure drugs is because all the clinical trials were based on whether you had focal seizures or generalized seizures. And that's the big problem. The symptom. We're treating the muscle weakness in polio. We're trying to invent the perfect iron lung, but that's not going to answer the question. It's researchers like Dr. Misra who get in the lab and figure out the gene for a particular disorder. That's the way we're going to solve this disorder. Now, I don't have a disclosure slide because we were limited in the number of slides. So I do a lot of clinical trials, and I can tell you every display I've done a clinical trial for. So I've done a clinical trial for Epidiolex, and that time was GW Pharmaceuticals, now bought out by Jazz. I did clinical trials for fenfluramine, which was Zonetics, which has been bought out by UCB Pharma. I've done clinical trials for lacosamide, which was a UCB study. I also did the clobazam studies for Dravet, which is a UCB Pharma. And I did the Moranis infantile spasm study for Moranis for ganaloxolone. I also did the CDKL5 study for ganaloxolone. And with Dr. Randall, knock on wood, we're going to have success in TSC, looking at ganaloxolone. But the crux is in this first slide. You got to know the natural history, the etiology, and have the patience to do a study on. And you need really bright and very novel thinking geneticists to figure out which gene that goes along with the natural history study. So I'm going to concentrate on one of the epilepsy syndromes that I'm most familiar with, which is Dravet syndrome. So let me give you a brief 10,000-foot view on Dravet syndrome. It's not common. It's found in 1 in 15,000 patients about. It's a genetic disorder. It's caused by mutations in the SCN1A gene, which is also the NAV 1.1 for those of you who care. And it's found in 90% of the patients who have Dravet syndrome. To this date, Dravet syndrome is still a clinical diagnosis. In the SCN1A gene, there's over 1,000 variants that have been associated with Dravet syndrome. The interesting thing, only about 20% have actually been validated with electrophysiology testing. But the vast majority of these variants in this gene cause a frame shift deletion, which gives you a genetic condition called haploinsufficiency, meaning that you only have one allele that's normal, the other one is not present because it's degraded. However, with the use of genetics, there's also a gain of function disorder with the SCN1A gene, which becomes very important. It's extraordinarily rare. But the two most common positions are listed on the slide. The reason why it's so necessary to know that is because in gain of function mutations, sodium channel blockers work and stop seizures. In the loss of function patient, it makes seizures worse. So that's just the little cartoon of what the channel looks like. It spans the membrane. It's closed most of the time. It's activated. It opens up and allows sodium to go through, causing nerve conduction. And it's mostly found, interestingly enough, on the interneurons, which are GABAergic neurons. So it's the inhibitory system of the brain trying to control too much activity. Now, most of us humans, me included with my little role over here, the opposite. I'm always inhibitory. I'm always on the couch. I'm always watching some old movie where I should be really active, right, and running around, but I'm not. Now, the interesting thing is this gene is actually not very well expressed at birth, but in development it increases in its expression. And at the 6-month mark, it crosses with its counterpart, the SCN3A gene. So if you actually treat a Dravet patient with a sodium channel blocker or levetiracetam, no offense, Jim, you're going to see a little bit of a benefit maybe, because you're acting on the 3A protein that's being dysfunctional. You're not acting on the SCN1A gene in particular because it's not fully expressed. Whoops, I should tell you there's a very regimented, but not completely universal epilepsy types that are associated with Dravet, and they come in a particular order. And that particular order is due to the physiology of the SCN1A gene itself, the way it's expressed, the way the inhibitory portion of the brain starts to come together as neurons keep migrating from, especially the GABA neurons that are migrating into the temporal lobe. The EEG for us EEGers is very classic, and a neophyte EEG reader will just call it slow spiking wave. It's slow, but it's not Lennox-Gastaut slow. And you can get mixed up if you are reading in the middle of the night and you just call it slow spike wave. The person that reads your report's going, oh, it's Lennox-Gastaut. Well, it's really not. But the last line is the most important. SUDEP is extraordinarily high in this disorder. But this disorder comes with all the comorbidities that our last speaker talked about. Everybody has intellectual disability. Autism is very high in frequency in this population. They have ataxia problems, they have attention deficit, they have sleep problems, they have gait abnormalities. It's really a difficult epilepsy syndrome to treat. And here's what I said that is really marked out. So, whoops. So that's my talk. Any questions? There it is. So, 3 stages. There are different types of epilepsy semiologies during each stage. There are different clinical manifestations at each stage. And if you see this little line right here, SUDIP is really high. And it's the one we really worry about. Now, the fall of clinical trials, remember, garbage in, garbage out. The FDA has mandated that all clinical trials using drugs in epilepsy start at age 2. Look at all the stuff that happened before age 2 that the drugs that we're experimenting on don't treat. So, when you look at the data, you have to think about what stage of the disease that we're trying to treat. So, what has the literature showed us? One of the reasons why we need genetics is because I can go in the literature and cull out all the data that's been reported in that particular gene. I can see what's worked, what hasn't worked, what makes things better, what does nothing. And revolving around the literature, sodium channels make seizures worse. In fact, what's really interesting is the length of use of sodium channel blockers is highly associated with the cognitive impairment and developmental problems. It's not just you need more GABA around, because vigabatrin makes this disorder worse. What's been found to work is a group of compounds that bind to the GABA receptor, which makes sense, right? Because somebody was smart enough to figure out, some researcher was smart enough to figure out where this receptor is highly expressed. Sodium, GABA channels. So what drugs are good on GABA tend to work for this syndrome. So, novel mechanisms. I'm sure most of you remember the Charlotte Figi story. So, she has Dravet syndrome. Nothing worked for her. She had 30 to 100 seizures per day. She lived in Denver, Colorado during the big marijuana boom. She was given an extract of marijuana, and her seizures went from 30 to 100 a day to 1 a day. It worked. Everything was advertised on CNN, it was on Time magazine. But in N01, you get the cart before the horse, right? Because which compound is it? So the reason why people smoke marijuana is because of the upper compound, which is THC, delta 9. There is a lot of research going on delta 8 right now for those of you who are into getting high. It's a much better drug. But the one below it is the real drug of choice in this syndrome, is cannabidiol. And because of that, GW Pharmaceuticals had the rights. They developed a clinical trial, and we were one of the sites. We were fortunate enough to actually do this trial. So, just a little bit to backtrack a little bit about the 2 different drugs. The upper one shows that THC binds specific receptors in the brain. Those are the receptors that get you high. So if you're a medicinal chemist, you want to activate the CB1 receptors to get people high. But CBD doesn't activate CB1 receptors. It's actually an antagonist. It actually activates a in-cannabinol system in your brain that's naturally present. It also activates some serotonin receptors, which becomes interesting later on. So it works. It reduced seizures by about 25%. The FDA loved it, they approved it. Is it a honeymoon effect from a 14-week study? No. In the open label phase, we went out 72 weeks. There was no difference in efficacy. So it doesn't downregulate receptors, it doesn't change efficacy at all. It's really a good drug. Now, the second drug, fenfluramine. If I had more time, I could tell you the interesting story about the group of kids in Belgium and how they were on this in the late 1960s and early 1970s, but I won't, I don't have time. But John Accardi treated patients using this serotonin drug because he thought that stress increased seizures. Well, he reduced stress and anxiety, but he also reduced seizures. He published it in the New England Journal as a case report. I think it's one of the only handful of case reports in the New England Journal, but it works. So a company, Zogenix, bought the copy for it, and we did a clinical trial. It has great kinetics, long half-life, steady state is fairly quick, and let's get back to the serotonin effect. It also binds specific serotonin receptors in the brain. Remember what Epidiolex did? Are we getting a theme here? So we were part of this study. It was, again, 2 to 18. It's what the FDA requires. Primary endpoint. And 62% seizure reduction, which is phenomenal. And in the low dose, quote unquote, 32%. Now, for those of you who have tried to prescribe it, there is no way on the face of the earth that you could get 0.8 milligrams per kilogram per day in a kid that weighs over 30 kilograms. The FDA has a limit on how much you can give, and it's like 26 milligrams per day. Anyway, this looks really good in the report, and we loved it. But in reality, you can't use that high dose. And does it work with other drugs? Stiripentol has been purported to work fairly well in the French study, but it actually still improves seizures by a great percentage. But here's the real crux of this slide. What we're after in treating seizures is seizure-free days, not necessarily just frequency reduction. So at high dose, per month, you get about 20 seizure-free days. If you're a parent, that's huge, right? You can go to work. You don't have to worry about being called from work. You can send your kid off to the babysitter or daycare and not worry about being called. This kind of data is just starting to come out in clinical trials. Epidiolex hasn't done this figuring yet, but it's really a powerful tool. So, summary. Precision medicine, we've got 2 drugs that work really, really well for Dravet syndrome to control seizures. But the true story is still going to be teased out because this disease is really being investigated intensely. So the future. There's a drug that's been used in the zebrafish model. It actually controls 100% of the larvae that have the gene transfected into it. That's phenomenal. Now, the fenfluramine and Epidiolex data that I showed there, that's from the CEO of the company that's doing clomenazole. So I take that by sort of a grain of salt. So we also are doing the anti-nucleotide therapy for these kids. It's in phase 2. We're still trying to figure out the proper dose. It does reduce seizures, but so far it has not been a slam dunk. There is a gene trial that's been purported, but unfortunately their vector causes liver failure and they're figuring out how to introduce the gene. So, at this part, I guess we all have questions now that we can be asked. Thank you very much. I'm in, so we can go home after this.
Okay, thank you very much, everybody. We'd be happy to take any questions that you have, or any from the... Then you get to be in charge of the microphone. You can't ask about the Belgium kids on fenfluramine.
Okay. Okay, thanks for those stipulations. I am curious how much you consider possible medication side effects. Of course, I'm primarily interested in cognitive and psychological side effects. When you're first prescribing medications, so perhaps with a patient with depression or behavioral problems, might you gasp not start with levetiracetam? Or do you kind of trial and then see how they respond?
I'll take that one. Yeah, so we don't always start with Keppra, right? Although I will say that just because a patient has pre-existing irritability or aggression or other sorts of things does not necessarily mean they're at higher risk for for levetiracetam causing those side effects. But absolutely, we take those into account and think about, trying other medications first. We have lots to choose from. I basically just try and choose the thing that's going to give you the most business, is what it is. Yeah.
Thank you. I don't actually need more business, but appreciate that. What is the literature around? I mean, I have seen some studies that say that they're at higher risk if they have pre-existing psychological comorbidities. I don't know, Dr. Hamiwka or Dr. Owens or any of you, actually, if you know anything about that.
I ask about that, and I do discuss that as a risk factor. So I do ask about family history, usually on the first visit, but that, again, time is always really difficult at visits. I have started to think more and more about potential effects or worsening effects, particularly around ADHD. And I know, when Dr. Owens was speaking, we have good evidence for ethosuximide in childhood absence. If I'm pretty definite that someone has ADHD, I may not start ethosuximide. I may say, look, there are other options, and I may actually start lamotrigine. So I really do actually think about that because I have seen worsening symptoms. Sometimes someone will come to me and there's either a question of that and even with valproic acid, right? I mean, it really cleans up the EEG beautifully, and it's, the end game of meds often when nothing else works. However, it's a balance. And so it's finding that balance and discussing that balance. And I will often open it up and say, we have options, these are the options, and then we can walk through and discuss it. But yeah, I think every time I do this talk, it makes me think about it more, and it makes me go back and think, yeah.
That was actually addressed in the NIH study that we were part of. So there's a series of papers on medications for absence, and then side effect behavioral problems. And there's also a paper on EEG findings. And I refer you to those papers. They're really good.
Okay, so the question is, how does Seattle Children's help get their patients that are aging out into adult care?
Yeah, thank you. We didn't really address that much in our talk today. We have a great partnership with the University of Washington and Harborview Medical Center's epilepsy programs. And typically we'll refer to those programs at 21, but really try and start that conversation early as age 16. I don't know about how you all do it.
No, I think that's a big issue, and I think certainly the more specialized, the more care that's required, that's provided Seattle Children's, the harder it is to transition them to adult population. So that's why we're trying to start earlier, but it is a multi-year process. And it often does involve transition to the University of Washington, but yeah, it's trying to make that process as smooth as possible. And many of these children have other comorbidities, other health issues, and so it's not just neurology, it's multiple subspecialists.
I'll just put a plug in. If we see kids that have TSC, for example, Dravet syndrome is another example, who see multiple specialists, we can refer them to a more comprehensive evaluation as they age out, and then it's called the Transition Medicine Program through the University of Washington.
Okay, the next question is, Curious about the logistics to refer patients living in Oregon. How long is the wait list for the epilepsy referral and the keto diet? Because apparently that's not available in Oregon. And I'm just going to ask this one more, so it's the same question. How do you handle insurance obstacles?
Yes, so that we have dealt with that a number of times in Oregon, just because they have decreased capability to do that there. It is a problem, so we actually have to work with insurance, work with out of region to try to get them. We also, crossing state lines is also problematic in terms of providing them direct medical care. We have to have them in the state of Washington in order to do a lot of the medical care. And that, certainly for things like the ketogenic diet or situations where you need very frequent visits, that's quite a bit of travel for families from Oregon, but we do have some families there. And it's really incorporating with out of region and making sure that that's a feasible option.
I'll put a plug in for our back office team is really helpful in helping us be able to see patients from Oregon and getting some of the services covered by their insurance companies.
How would you recommend the patient from Oregon, reaching out to start that process? What number should they call? Who should they call?
Usually we have the person referring them place a the primary physician will place a referral to Seattle Children's Neurology.
I just didn't know if it was different for out of state, so okay. And then this question is, did I read the slide correctly that the risk of SUDEP increases with age, not just with people with Dravet, but with people suffering refractory epilepsy in general?
Yeah, that's correct. Yeah, the risk of SUDEP does increase over time with age.
Some diseases are worse than others. Dravet happens to be a really bad epilepsy syndrome with SUDEP. So it does vary a little bit, and at least in several years ago when we wrote the paper with the Cleveland Clinic folks, SUDEP does not go down in frequency compared to the general population unless you are seizure-free completely, and that usually means epilepsy surgery. So anytime you have seizures that are ongoing, you're at a little bit higher risk for SUDEP. It's only when you're completely seizure-free, and most of the time it's seizure freedom because you were fortunate enough that you had a lesion and you could go through epilepsy surgery.
Okay, the next question is, when do you decide that the patient will be a good candidate for the ketogenic diet?
So I think it was somewhat appropriate that they put me after Dr. Owens, because we often really do consider medications as something to consider first, just because it's so much easier to maintain. But really, in the people who do not tolerate medications, either because they're not effective or they lead to too many side effects, children that are on multiple medicines, we really encourage them to undergo a comprehensive epilepsy surgery evaluation. And so you're looking for, is there the potential for a cure, or do they have something that is not amenable to a resection, or they have a genetic syndrome that is not amenable to a surgical procedure. And then that's the type of thing where I think it's worth an evaluation for the ketogenic diet.
That's all from the chat box.
Sorry?
That's all from the chat
Okay.
box.
We're happy to take, perfect.
I don't need the mic, I have a loud voice. Just curious, on the keto diet, do you ask families to monitor ketones with blood ketone or urine ketone checks, or is just following the guideline of 15 carbs or less a day sufficient?
Yeah, so that's a great question. Historically, we have not recommended doing any home blood monitoring. We really encourage families to monitor the symptoms and teach them what it looks like when they have low blood sugar or their ketones are too high. With the pandemic, a lot of that changed because we didn't want to bring them in as frequently, and so we actually have become a little bit more proactive about giving them home monitors either for ketones or glucose. And so some families use that. We discourage using that as the main source of information because we really want them to go by how the child is doing clinically, but it can be another source. We still prefer getting the full blood labs to really make sure that we're looking at everything, not just that.
Great. Thank you for another great session. So I had a question. I was really struck by your image between the researchers and clinicians in developing of, clinical trials and disease models. And I think, one aspect that I'd love to hear your opinion on is how Seattle Children's and you all in your practice incorporate the patient voice into clinical trial development, and also from the research side, how do you, ensure the patient voice is heard in developing appropriate disease models that really model appropriate disease indications?
With the advent of genetics, we can actually create animal models using gene editing techniques. So we can create our own models for different types of epilepsy. For instance, we have a Dravet mouse, and that Dravet mouse, we can knock out the abnormal gene and just have the normal gene being expressed at any time in the mouse's life. So that gives us a good handle on what medications work when. There is a Rett syndrome mouse model, and that's the clinical trial that we just finished looking at trofinamide, and that's how that drug was discovered. So mostly it's the researchers taking our information, creating model systems, and then evaluating different drugs, medications that may possibly work in that model system based on the biochemistry and the physiology of that disorder. There's a lot of buy-in from family groups, like the Dravet Foundation family group. There's a lot of pressure to develop gene therapy, and that's moving along, but there are roadblocks. Not everything works for everybody, and unfortunately, although most of us know people who really mimic rodent behavior, rodents are not humans. And so you have to take that into account too. Like the zebrafish model, that model was developed by a guy at UCSF, and he has a great model system because zebrafish can populate to no end in a small fish tank. And he can analyze hundreds and hundreds of drugs to see which ones make seizures stop. And that's how clomenazole was discovered. He also has gone on to look at different CBD types and which work and which don't work in a zebrafish model, which is highly intuitive and makes us know where not to venture for a clinical trial. So the researcher is extraordinarily important, but the researcher doesn't have enough information without the clinician. They need to know the natural history. They need to see how the patient does over a period of time. They need to see how that variant may change phenotype that we may not understand, because there just isn't enough patients. So your N has to be quite large. It can't be an N of 1. You really need to have large populations to really study. And so that's where the researcher comes in, but the family groups are the collection of patients. And they allow us to see them, what their disease is like, how it progresses over a period of time, how it presents. Then we can rationally and intellectually develop clinical trials that fit sometimes. Like I said, like the Dravet clinical trials, they're all 2 and above. The companies are just starting to loosen up with the FDA to study younger children. So there are constraints on clinical trials. But it's really an integrative process from researchers and clinicians, but there's a lot of family input as well. And you need those family groups to really have good input because they're the ones with all the patients, right? A particular individual clinician may only have a half a dozen, where family foundations have hundreds. So they're really valuable.
Okay. As a follow-up question, is there, I mean, I think Scott Baraban, who developed zebrafish models, it's great because he's on the science advisory board for, Dravet syndrome. But I think other, as families or patients or patient advocates, are there specific tactics that you would suggest to help provide the patient input in developing the disease models or developing the specific endpoints for clinical trials?
Yeah, and I think that Dr. Misra knows as much about this as I do. So there are websites called Gene2Me, and there are other websites where families can meet other families with the same disorder. So I'm just going to give you an example. I'm not doing this at all. But I have a patient with a rare mitochondrial disease. And actually, they found another patient in Louisiana. They found another patient in Sweden. The patient in Sweden knows 2 more in Spain. The Spain people know a couple patients in Japan, and they all got together. So we were able to devise a little clinical trial based on that small number. So that's really interesting. And that's something that families can really do. They can find other families on Facebook or Gene2Me and then rally around the troops. And then they find some investigator that has a huge interest in doing research on that particular gene, because that's what they have their NIH grant. And on an NIH grant, if you don't know, you have to give a little section about why your grant makes sense to fund. And you can cite, a terrible epilepsy syndrome that may be treatable if my research comes out well.
Well, if we don't have any other questions, I'd like to thank everybody for coming today. I'd like to thank our speakers, and please stop by the tables we have over on the right to take home any handouts that you might like. And thank you again. Have a great day.